Okay, don't let arrhythmias intimidate you. Okay, so we're just doing basic arrhythmias for the exam, and I've never had students come back from after taking the NCLEX that say, "Oh, we never discussed this in school, and I got this question on arrhythmias." Never, because that means everything that's basic from the textbook was enough for you to answer what comes out on the NCLEX. Does that make sense? All right, so we'll just do basic. For exam questions and the rhythm strips that I'll be using, all of them will come from the textbook. Okay, nothing, because let's say atrial fibrillation, that rhythm can come in different forms. There's over a dozen ways that AFib can look like, okay, on a real patient on a cardiac monitor. So to be fair, not all of you have experience with dysrhythmias, so I will only use the strips that are available on the textbook. Are we clear? All right. There are 5 possible questions on each rhythm strip. They are: 1, what does it look like? Meaning, I'll show you a rhythm strip, then the question will simply be, nurse recognizes this as what? All right, that's one question. Next is, what causes it? Because not all dysrhythmias are treatable, or they don't require treatment. So therefore, all we need to do is either monitor and then try to eliminate the underlying cause. For instance, some dysrhythmias are caused by a patient straining. Say they're constipated, hasn't had a bowel movement for 7 days, and they kept straining. So that can cause sinus bradycardia. So therefore, the treatment will be treat the constipation. Okay, tell the patient stop pushing, give them a laxative or stool softener, okay, increase fiber, etc. Or if the patient is, let's say, um, smoking, for instance, okay, so let's say PVCs. PVCs depends. They're generally harmless if the patient doesn't have any cardiac history. So most triggers are coffee, for instance, or patients drinking 7 cups of coffee before lunchtime. So there you go. There's the cause. All right. So that's the second question. What are the causes? 3 is the easy part, because 3 is the signs and symptoms. Now, there is no dysrhythmia that increases cardiac output. All dysrhythmias, varying just in the severity, all of them cause decreased cardiac output. So therefore, is the signs and symptoms going to be different from one dysrhythmia to another? No. Number 4 will be the interventions. Now, the interventions are not always medications. I'll say majority, yes, we use medications to treat them, but not all the time. Okay? And then, so therefore, your interventions will either be pharmacologic or non-pharmacologic. Then number 5 is teaching. What do you teach the patient? Of course, we will teach them what causes the dysrhythmia. So if they avoid the cause, then they'll avoid the dysrhythmia. And then medications, of course. Any question? So those are for each dysrhythmia that we cover today. Those are the 5 possible questions. What does it look like? What are the causes, signs and symptoms, interventions, pharmacologic and non-pharmacologic? And then 5 is the patient teaching.
So for us, this is how it looks like, right? So like the hospital machine that you have to say.
There are rhythm strips on your textbook. Those are what will be seen on your exam questions. So whatever's on this particular edition.
Okay.
All right. Okay, so let's begin. As I said, dysrhythmias will cause decreased cardiac output. So this is one of the causes of heart failure. The severity will vary. Some dysrhythmias are harmless, some are moderately harmful, some are fatal. All right, so let's get to know the most common ones. First of all, let's look at the normal electrical conduction first. So let's see what it's supposed to be first, and then we can recognize any abnormalities. All right. So we have three pacemakers of the heart. There's a primary, which is the SA node. There's a secondary, which is the AV node. Third, or the tertiary, are a combination of the left and right bundle of His, and all the way to the Purkinje fibers. Again, there are three pacemakers of the heart: the SA node, the AV node, and the left and right bundle branches, all the way to the Purkinje fibers. I'll show you a picture on the next page. Now, the SA node is the primary pacemaker. It is capable of firing 60 to 100 electrical impulses per minute. So we rely on the SA node every day in order to have a normal heart rate. The AV node is a secondary pacemaker. It's like a backup. However, it's only capable of firing 40 to 60 beats per minute. So yes, it can sustain life, but not for a long time. The tertiary, which are the left and right bundle of His, all the way to the Purkinje fibers, they're not worth talking about. Let's not even consider them a pacemaker, because they can only generate 20 to 40 beats per minute. Now, is that enough to sustain life? No. So that's what I'm saying. Forget about it. Okay, even if they're firing, it's not going to keep anybody alive. All right. So only the SA node we rely on every day. And once that fails, then patient will require a pacemaker, because the AV node, yes, this can sustain life, but not for a long time. Okay. So if the SA node fails, then the patient will require a pacemaker. Okay. Any questions so far? All right, let's go to the picture. First of all, let's finish this one. There are many factors that will affect the heart rate and contractility. So not just the electrical impulses. We are influenced by the autonomic nervous system. So these are the hormonal responses. For instance, once the oxygen levels drop, blood volume, blood pressure, sugar levels drop. Of course, the autonomic nervous system kicks in, right? So these are the fight or flight hormones. So we got epinephrine, norepinephrine, which increases the heart rate, correct? All right. And we've got the other, the counterpart, which is the parasympathetic, which is stimulated after a meal, for instance, or by certain drugs. So after a meal, you notice that you get sleepy, right? You're tired because the parasympathetic system takes over, which reduces the heart rate and causes vasodilation and shunts blood away from the heart, the brain, and the lungs, and concentrates the blood flow to the GI tract. Okay. So those are examples of influences by the nervous system. Other factors that will increase or decrease heart rate are the following. So we've got sympathetic stimulation caused by exercise, anxiety, fever. These medications. Now, these will be mentioned as one of the few causes as we go through the different dysrhythmias. So these are identified as factors that will cause certain tachydysrhythmias. And then we've also got some medications or activities such as, for instance, training that will decrease the heart rate, causing bradydysrhythmias. ECG. The machine was invented by Dr. Einthoven long ago, and he demonstrated and illustrated it on a ECG paper. So on the next page, we will discuss how to measure and identify waves and complexes are shown on an ECG paper. What do those horizontal and those vertical lines mean on the paper, right? Okay, let's start here. What you're looking at is the Einthoven triangle. So this is an imaginary upside down triangle illustrating the relationships of the 10 leads of a 12-lead ECG, which gives us 12 views. So what you're looking at is the heart. So imagine there's a head on top of that. There are shoulders on each side, and then the torso right in the middle. Okay, so where the heart is, and then imagine there's a left and right lung there, and then the GI tract, GI organs below. Okay, and then you've got the right and the left leg where that heart is located. As you can see, the leads, there are 10 leads. They are located, let's see if it's on the next picture. Okay, so this is the placement of the 10 leads of an ECG. So we've got one on each limb, right arm, right leg, left leg. Now, there is, the right leg has no pole, meaning it's just a ground lead. Based on, electrical conduction, we need a ground lead in order for electricity to flow, because otherwise there will be a, you understand what I'm saying? Like on your electrical outlets, for instance, there's a ground, right? Okay, in order for electricity to run, because otherwise we will have short circuits. Okay, if it's not grounded on something. So this is the placement. So you have two leads here on the on each sternal border. Second intercostal space, that's where you put V1, V2, and then right below that would be V3, 4, 5, and 6 will be right here on the side, which is mid axillary. Okay, so that's the placement of the 10 leads. Now the 10 leads give you 12 views. Again, there are 10 physical leads which give you 10 views. Why? Because we go back up here. This lead is bipolar. Look at the lead on the left arm. It carries both a positive and a negative. Because of that, it will give you 2 views instead of 1. Okay, so that completes the 12 views. But now when we say 12 views, consider it a 360 view of the heart. I'll show you an ECG paper, a 12-lead ECG paper reading shortly, which will give you a different view of the cardiac cycle of the waves and complexes, depending on which view is it taken from. For instance, when we say left arm, this view right here on the left arm, because it's bipolar, the line of sight is actually, this is not testable. Okay, I'm just trying to explain why the view is such. So let's say this one on the right side is lead 2. Lead 2 is capturing electrical activity from the right arm all the way to the left leg, which is parallel to the electrical conduction pathway, since the pathway starts from the SA node to the AV node and then to the left and right bundle is all the way to the fibers. So it's going this way, right? So it's lateral from the right shoulder to the left leg. And since lead 2 is parallel, so lead 2 in most of the figures you'll see on this chapter, most of the ECG tracings you'll see are taken from lead 2. Lead 2 resembles the most almost perfect visualization of electrical conduction representation. Okay, and lead 1 is on top, meaning if you think of the 12-lead ECG as 12 photographers, 12 professional photographers, this is where they're sitting. So lead 2, the photographer is taking a picture from this side. Lead 1 is taking it from the top looking down. Lead 3 is taking it taking a look from the left side of the heart, and then so on. So when we say, when we look at lead 4, 5, 6 later, because they are placed here, so they are looking at the base and posterior part of the heart. So again, there are 12 different photographers here taking pictures from different vantage points. So therefore, when you look at the 12 lead ECG, it will not look the same because they are looking at the electrical conduction from a different angle. Does that make sense? Now, how does this factor into diagnosis? Now, the doctor, not us, can make a diagnosis based on a 12 lead ECG. For instance, if he's looking at a heart attack, where exactly is the heart attack most likely occurring? Meaning which coronary artery is blocked and therefore showing some injury to the myocardium. And then he can make a diagnosis, oh, this is a posterior wall MI, okay, or etc. Depending on which lead shows the change. Does that make sense? Again, this part is not testable. We're not diagnosing anyone. So we'll just stick with the interpretation. Okay. And then again, what are the 5 questions we need to answer? What is it?
What causes it?
Causes,
Signs and symptoms.
signs and symptoms.
Interventions and treatment.
There you go. We will focus on those. Any question before I proceed?
I do, so we
Okay.
only put 10 leads on the patient, right? Even if we're doing a 12 lead.
Yeah, because there are no 12 leads. There are
Okay.
only 10
Because there's
leads.
nowhere to put it.
Yeah. So we put them on. So this is the protocol. So whenever you have a patient complaining of chest pain, that's always suspicious for a heart attack, so, or any form of ischemia. So we put an ECG. You of course notify the physician, but you know the physician's gonna order a 12 lead ECG anyway, and it's your patient. So you want to facilitate the diagnosis. So you put them on while the doctor is coming.
Oh.
Right, while the rapid response is coming. So, I mean, you can get the order later.
Okay.
Okay, so we just put it on because when we know from experience, they can order it anyway. Okay, right, and it's your patient, it's still your problem. So you want to facilitate the ECG reading. That way, when they come in, they see the changes, we can proceed with interventions right away, rather than you waiting there, just nothing, waiting, hey, wait, doctor's coming, and then doctor comes, okay, where's the ECG? How come you haven't done one yet? Oh, okay, didn't order anything. Okay, so that will delay, again, treatment. Okay, so you want to get it, you want to put it on ahead. That way, but because it also takes time. Let's say your patient's not cooperative, patient has dementia. So it can be challenging. Okay, so patient keeps moving and then the machine will capture a lot of artifacts because if the patient's muscles are moving, then it will capture electrical activity from skeletal muscles as well, disrupting your reading. All right, so you want to get it done as soon as possible. Yes.
I'm sorry, I might so sorry. What's the difference between, ECG and ECG?
Same thing.
Same thing?
Yeah.
Okay.
Now you can't rely on a cardiac monitor. So let's say you work on telemetry. So we have 5 leads for a portable 5 lead telemetry box. So that only gives you a limited view. So it's not enough because the most you'll see is probably 3 or 5 views. So we need 12 views. Okay, we need a 360 view of the heart. So it's still the standard to use a 12 lead ECG. There are 24 and 36, 48 leads now, but the minimum is 12. Okay, so that's still the standard, yes.
So like when I visited my family member in the hospital, she was connected to
Monitor.
cardiac monitor
Uh-huh.
at bedside.
Yes.
But then when she got up, when the PCA came, the PCA had to do the 12 lead, but he bought another machine.
Yeah.
And he disconnected her from the one. So what's the difference? That one doesn't do the 12 lead?
Again, that's only 5 leads versus 10.
Okay.
Okay, so therefore, I mean, 5 electrodes versus 10 electrodes. So no comparison.
So they don't have the ones on the arm, right?
That is only taken as needed. We can't put someone continuously on, I mean, the patient will be restricted, right? Because we
Okay.
got 10 leads on them. All right, let's look at now what each wave and complex represents. So we'll base it on this picture right here. Okay, so we've got PQRST. So this is the P wave right here. This one here is the P wave. And then we look at the PR interval. Sorry? Yes, this first wave here is called the P wave. And the this wave right here is called the QRS. And then this is the T wave. You'll notice that, well, this is a drawing. This is not an actual reading. So on an actual reading on a patient, it never falls on a solid line. It always falls in between solid lines. Okay, so the imaginary straight line that you'll see later is called the isoelectric line. And then we base the measurements of the waves and complexes from where it leaves the isoelectric line to where it returns to the isoelectric line. I repeat, we measure each wave and complex from where we start measuring it from where it leaves the isoelectric line. What is the isoelectric line? It's an imaginary straight line. So once you see a wave leave the isoelectric line and then return to the isoelectric line, that's the point of measurements. Okay. The horizontal lines, as you can see on an ECG paper, there are dozens of horizontal lines and vertical lines. Horizontal lines measure time in seconds. Vertical lines measure voltage in millivolts. Okay, I repeat, there are horizontal and vertical lines on the paper. The horizontal line measures time in seconds, and vertical lines measure voltage in millivolts. Okay. Each small box, it's not very clear here for big boxes and small boxes. I'll use another figure to illustrate it, but as of now, you see small boxes, correct? Each small box measures 0.04 seconds. Again, each small box measures 0.04 seconds. Are you clear with that one? Okay, we'll do more later. 0.04 seconds. Because the first step in interpreting a cardiac strip is to count the heart rate. So we'll use that in order to count heart rate. All right, and as well as measure the duration of each wave and complex. So what is a P wave? When we see a P wave, there are two things that happens when we see a P wave. That's why it's important to see a P wave. P wave represents electrical impulse starting from the SA node, spreading through the atria. P wave therefore represents atrial depolarization or atrial contraction. It's normally 2.5 millimeters in height and less than 0.11 seconds or less in duration. Meaning, how many small boxes is it? Between 2 to 3, because 3 will be 0.12. Yeah? Okay, so it's usually 2 to about 2, but less than 3 small boxes. It says at least 2, but less than 3. Okay, 0.11 seconds. So how do we measure the P wave? From where it leaves the isoelectric line, starting here, to where it returns to the isoelectric line. Okay, so as you can see, it's clearly less than 3, correct? At least 2, but less than 3. So what 2 things happens when we see a P wave? That means the electrical impulse, the heartbeat that you're looking at, came from the SA node. We want every heartbeat to start from to be stimulated or initiated by the SA node. So when you see a P wave, that means where did the electrical impulse come from? The SA node. And what happened when we see a P wave? What contracted or what depolarized? Both atria. So if we go back to the picture again, since this is the SA node right here, you see this branches here that have the branches going to the left atrium. Okay. So think of the electrical impulse. So we can't see electricity, but we've seen lightning, correct? Okay, so a few nights ago, we had some storms, right? So you've seen at some point in your life, you've seen lightning appear in the sky and then hit something in the horizon, correct? Did it take a long time to do that? It was over before you knew it, correct? Yeah, like diarrhea. Okay, like diarrhea. Oh, are you having diarrhea? Poof, it's already there, right? It's already in your pants. So it's that fast. So when the electrical impulse is fired by the SA node, you think it will take a long time for that to reach the left atrium? No, instantaneously. So when that happens, that means will the right atrium contract first, followed by the left atrium, or will they contract at the same time? Same time, because electricity travels so fast, right? Okay, so when you switch, let's say, switch the light on, did each light bulb come on faster than the other? No, so same idea, right? Okay, so that's how fast the electricity travels. Now, the pathway for the electrical conduction is when the SA node fires an electrical impulse, yes, it reaches the left atrium, but you think it will also take a long time for it to reach the AV node and then down here? No, it will also go, yeah, just like the light switch right here, that fast. So therefore, once the SA node fires, then it shouldn't take a long time for that to reach the ventricles, correct?
Yeah.
So this one pathway, same electrical connection, right? However, imagine that scenario. If the electrical impulse traveled that fast, then that would mean that the atria and the ventricles should contract at the same time, correct? Now, do we want that to happen?
No?
No, because if both of them contract, if both atria and both ventricles contract at exactly the same time, there is no blood movement, right? Because it has to be atria first, and then where does that blood go? To both ventricles, and then once the ventricles pump, they will go to the right side will go to the lungs, the left side will go to the aorta. Okay, very good. So that's how it's supposed to be. Okay, so you follow so far? I'll explain what happens next shortly. So the left and right atria will contract at the same time, and when that happens, we see what wave? The P wave. Okay, you understand so far? Okay, so on the ECG, as you're looking at the heart monitor, once the P wave appears, what 2 things happen?
The SA node and the electroactivity.
Is SA node fired the impulse, and what happened? Both atria contracted. So is it important to see a P wave?
Yeah.
Yes, we're happy to see a P wave. We see a P wave, yay! It's a normal impulse, meaning SA node fired that thing, and then the atria really contracted. They contracted real time. Okay. The next wave is the PR interval. Now, don't be deceived when it says PR interval, because that wave is measuring the P wave up until the beginning of the Q. So look at the measurement here. PR is measured from the P wave all the way to the Q, before the Q. It doesn't include the Q. So if you ask, why is it called the PR interval? I have no idea, because the R wave is all the way here. We're not measuring the R wave. All right, but that's what they call it, PR interval. So what is the PR interval? Okay, someone read for me, please.
The PR interval is measured from the beginning of the P wave to the beginning of the QRS complex and represents the time needed for sinus node stimulation, atrial depolarization, and conduction through the AV node for ventricular depolarization.
It
In adults, the
measures.
PR In adults, the PR interval normally ranges from 0.12 to 0.20 seconds in duration.
Okay, so how many small boxes is that? It says 0.12
0.04, so that's, at least 3,
to
5.
3 to 5 small boxes. Okay, very good. Okay, keep in mind the definition. PR interval includes the P wave, correct? So therefore, it includes the sinus node stimulation, atrial contraction, and then conduction through the AV node before the impulse is transmitted to the ventricles, to the left and right bundle of his. This is now the importance. The PR interval proves the importance of the AV node, because just like the light switch right here, so it's supposed to, as soon as the SA node fires, it's supposed to transmit it all the way to the ventricles, correct? But the AV node did not allow that to happen. So the PR interval proves that the AV node, yes, it received the impulse, but it did not transmit it. It held on to the impulse for how long? 0.12 to 0.2 seconds. It did not transmit it. It held on to it for how long? 0.12 to 0.2 seconds. Why did it hold on to the impulse? What did it allow to happen first? It allowed blood to leave the atria and enter the ventricles, and then it transmitted the impulse, allowing QRS complex or ventricular contraction to occur. Does that make sense?
Yes.
Okay, so therefore, do we need that PR interval?
Yes.
Yes, that is very crucial. Yes?
About
Which part?
So,
Okay, the QRS complex represents ventricular contractions, meaning the ventricles, both ventricles contracted. So the PR interval, again, includes the time that it takes for atria to contract, correct? Because it includes the P wave. So this is where the SA node fired, and then there's a delay of the transmission. For how long? 0.12 to 0.2 seconds. Why did the AV node do that? Why did it delay the transmission? It wants to allow ventricles to fill with blood first and then transmit it, and then the ventricles will contract. Now we have blood coming out. We got cardiac output. Yeah?
Yeah.
Okay, so it's very important to have a normal PR interval. Now, think of it this way. So the PQRS and then T is one heartbeat. This is one heartbeat. Okay? So that completes one cardiac cycle. Blood enters the heart, blood leaves the heart. Okay, one cardiac cycle. So if we have a really fast heartbeat, so let's say instead of 60 to 100, we've got 150 to 200. What will happen to the PR interval? Because the time will not change. Our time, minute by minute, is only 60 seconds. So now if you fit 150 to 200 cardiac cycles in the same 60 seconds, what will happen to the duration of your
It's
PR
not gonna
interval?
be there.
It's going to be very short. So what happens to ventricular filling?
It's not.
Non-existent, right? So therefore, does an increased heart rate benefit anybody at all?
No.
No.
Maybe for a few seconds, right? So because that's what happens during sympathetic stimulation, correct? When we're in fight or flight, yeah, doesn't our heart rate increase?
Yes.
But it helps only improve cardiac output for maybe a few minutes. But if that's sustained, what happens to cardiac output overall? It's gonna drop. So is it an efficient way to respond?
No.
No. So you have an idea? All right. So we know the P wave, then the PR interval. Let's look at the QRS complex next. So what is the QRS complex? So what does this electrical wave here represent? Thank you for reading. Maurice.
The QRS complex represents the trigonometric polarization. Not all QRS complexes have all three waveforms. The Q wave is the first negative deflection after the P wave. The Q wave is normally less than 0.04 seconds in duration and less than 25% of the R wave amplitude. The R wave is the first positive deflection after the P wave, and the S wave is the first negative deflection after the R wave. When a wave is less than 5 millimeters in height, small letters QRS are used. When the wave is taller than 5 millimeters, capital letters QRS are used to label the wave. The QRS complex is normally less than 0.12 seconds in duration.
Okay, so long story short, QRS represents what? Ventricular depolarization. And how long should it be? Less than?
0.12.
Meaning how many small boxes is that? Less than 3. Okay, or 3 or less. 0.12. No longer than 0.12. What if it is longer than 0.12? So how will we describe the QRS complex?
Capital QRS.
Okay, so that means it's also a wide, right? So wide QRS complex, meaning why is it taking the ventricle such a long time to depolarize? Yeah, that's another way of saying it, correct? And also, if it's too narrow, that means why are the ventricles contracting so fast? Correct? All right. Yes.
I think because for me, it just.
Okay, so here's the measurement. So each big box, so this figure now shows us small boxes and big boxes. So these are the small boxes, no doubt about that. But you know that there are big boxes, right? So you see this big box. So one big box is 0.5 millivolts. Remember, vertical axis, vertical lines measure voltage in millivolts. So one big box is 0.5 millivolts. And what did the description say? If the QRS,
Five letters QRS has the line. Okay.
okay. Okay, so again, this is
Capital R.
5 millimeters. Okay, so each big box is 5 millimeters. So this one, is it bigger than 5 millimeters?
Yes.
Yes, it's bigger than one big box. So if it's shorter, meaning one big box in height or less, then it's
QRS.
yes.
Capital.
So that means what happens to the voltage? Is it high or low?
Low.
It's low voltage. So that can occur in usually electrolyte imbalances. Okay, well, we'll discuss that later when we get to dysrhythmias.
Okay.
Next is let's do the ST segment first. E, QRS. I'll go back to the T wave. Let's look at the ST segment first. So what is the ST segment? It's this section right here. This very short isoelectric period. Okay, meaning it's flat. So therefore, is there any electrical activity going on there? No. Okay, so someone read, what is the ST segment? Thank you, Ms. Randall.
Segment which represents early ventricular repolarization lasts from the end of the RS complex to the beginning of the T.
Okay, I'll pause for a minute. So remember, we measure each wave and complex from where it leaves the isoelectric line to when it returns, correct? So since the S wave returned to the isoelectric line here, that's where we begin measuring the ST segment. The T wave did not start here, it started here, correct? This is where it left the isoelectric line and it's measured up to here where it returned to the isoelectric line. So this is the ST segment. Continue.
The beginning
Eric.
of the ST segment is usually identified by a change in thickness or angle of the terminal portion of the QRS complex. The end of the ST segment may be more difficult to identify because it merges into the T. The ST segment is normally isoelectric. Later.
That's
later in
fine,
the
that's fine.
session- Oh, it is analyzed to identify whether it is above or below the isoelectric line, which may be among other signs and symptoms, a sign of cardiac ischemia.
Okay. So later, when we go to acute coronary syndromes, which is next semester, the ST segment is normally what? Isoelectric, supposed to be flat. Now, in the case where it becomes okay, so ST segment can either be elevated, meaning instead of starting here, it starts here. The ST will deviate. ST segment starts here and looks like that before it becomes a T wave. Okay, we call that ST elevation. So that's classic myocardial infarction, patients having an active heart attack. Or it can also be in non-ST elevation MI, still an MI, wherein it looks like this. So what's the difference between the two? It indicates,
Oh,
that means in the ST elevation, say this is the chambers of the heart, right? A heart attack occurred, which killed off the entire thickness of the myocardium, meaning a whole section of the myocardial muscle died because of no blood flow. Okay, usually a blood clot. So the patient had a massive heart attack. So therefore, since T wave represents repolarization, meaning the cardiac cells here are repolarizing, meaning calcium and potassium are going in and out of the cell, becoming more positively charged. It's not doing that. It's doing it because it represents there's now early repolarization because these cells died. They will not repolarize. However, there are still living cells remaining here. These ones are the ones repolarizing, not the one that's dying. I mean, that's already dead. So that's what we call ST elevation. Now, in ST depression, on the other hand, it's still a heart attack. However, it's not full thickness infarction. Yes, some cells died, but only this part died. There are still living myocardial cells here, meaning the heart attack is not so severe. Yes, the patient had a heart attack, but blood flow, yes, was restored. So it only killed off this section, only a section of the thickness of the muscle. So therefore, yes, it still repolarizes, but not all are repolarizing. Only these are repolarizing. So that would appear that way. Okay, you follow? All right.
So-
Anyways, we'll talk about heart attacks next semester. Yes.
Okay, no, I was just gonna add, like, so, and the, ST intervals on the top.
ST
goes like
segment.
On the ST segment on the top. Like,
Uh-huh.
that's, MI
That's
as
an
well, but. it's just
ST
severe.
elevation MI. Yes, severe
Severe.
type of MI.
Okay, and then in the one in the bottom is not as severe.
Yep.
So the one on the top is life threatening?
Yes, so the ST elevation here. Anyway, you can fix the ST elevation, right? That requires immediate cardiac catheterization. Patient needs to go to the cath lab. The ST depression, since yes, the patient had a heart attack, but not anymore.
So they'll give like.
Yeah, so we have time, like 6 hours, maybe we can, yeah, we'll do it, but then maybe, overnight, we have 6 hours to take care. But think of it this way, it's too late. Patient had a heart attack, but then the blood flow was restored. All right, does that make sense?
Yeah.
If we see ST depression. And last wave will be the T wave. What is the T wave?
The T cell is a protective guard for the resting state. It follows the QRS complex and moves in the same direction, each section as the QRS complex. Atrial repolarization also occurs when it's not visible of the ECG because it occurs at the same time as ventricular repolarization. Example, QRS.
For the U wave, let's forget about the U wave because in practice you probably won't see the U wave. I mean, I see it every now and then, but not all the time. When the U wave appears, these are the causes. The patient has either hypokalemia, hypertension, or heart disease. But most of the time, it's not visible. Okay, I don't see the P wave 90% of the time. Okay, or not even, maybe 95%. I don't see it. Very seldom do we see the U wave. So the T wave represents simply ventricular repolarization, meaning it's starting to get positively charged again in preparation for the next heartbeat. Okay. As stated on the same paragraph, if the ventricles repolarize, then that means the atria should repolarize somewhere, right? But as explained, it probably repolarizes somewhere here. And if this is the only voltage you see during atrial depolarization, that means the voltage would even be smaller for it to repolarize, correct? So of course it would be buried somewhere there. It's not visible. Any question on the waves and complexes? All right, so whenever you see the cardiac rhythm, are you able to identify what's happening when each wave appears?
Yes.
Okay, very good. We won't do all the steps. We will only do a few steps. First step is always determining the heart rate. So whenever we see a rhythm strip, first thing we'll count is the heart rate. What is the heart rate? There are a few methods. There are 3 methods mentioned here. It's not practical to use a 1-minute strip because a 6-second strip is about this long. So imagine how long a 1-minute strip would be. So if this is 6 seconds times 10, go ahead. Do we have enough space at the nurse's station?
No.
Or do we have the space to put it on a notebook? No, it's very impractical. So all we need is we need a 6-second strip, and whatever we count, multiply by 10, that's our
Heart rate.
estimated heart rate. We only call it estimated because the only accurate heart rate will be a 1-minute strip, which again is very impractical to do. So we only do an estimated heart rate, which is using how many seconds? 6 seconds. Okay. So all the strips you'll see from here forth are all 6-second strips. Okay.
So on your quiz next week, we'll have to, it'll be 6
You'll
seconds.
see 6-second strips.
And then if you ask us how much, we'll have to times it by 10?
Yes.
Okay.
All right. So let's look at the first method. So an easy and accurate method of determining heart rate is with a regular rhythm is to count the number of small boxes with an R to R interval and divide by 1500 by that number. Okay, so where did we get 1500? How many is how much is one small box?
0.04.
0.04. So therefore in 60 seconds, how many small boxes are there? 60 divided by 0.04 equals
1,500.
Okay. That's where we got 1,500. Clear?
Yeah.
Okay. All right, so let's use that method. Let's try this one. So each big box is how many seconds? If
Zero
one small box is 0.04 times 5, there, how many seconds is one big box? 0.2, right? 0.2 seconds. Okay. So 3-second markers. So let's make 3-second markers. There's none on this strip. There's usually a marker, but none on this sample. So let's make our own 3-second markers. So since each big box is 0.2 seconds, so how many big boxes in 1 second?
5.
5. Okay, so therefore, every fifth box is 1 second, correct? 1, 2, 3, 4, 5. And that's 1 second. 1, 2, 3, 4, 5. 2 seconds, right? 1, 2, 3, 4, 5, 3 seconds. So this is a 3-second marker right here. Then let's make another 3-second marker. 2, 3, 4, 5, 7, 8, 9. Then another marker. So from here to here is 3 seconds. From here to here is 3 seconds. There's our 6-second strip. Got it? That's our 6-second strip. So the fastest way, can you say that this cardiac rhythm is regular or
No.
irregular?
It's irregular.
What made you say irregular?
Because there's no P.
No, when I say regular, that means are the waves and complexes occurring about the same time
Yes,
each
yes.
time? Let's see. Okay, so that's a P wave, that's a P wave, that's a P wave, P wave. So if we mark from P wave to P wave, are they occurring at the same time?
Yes.
So that's one P to P. From that P to this P, is it the same?
Yes.
From that P to that P, is it the same?
Yes.
From that P to that P, is it the same?
She is always small.
Yeah, P is always small.
You show that with more zoomed in. Yeah, because it was, oh, okay.
Are you okay?
Yeah, I'm okay.
Alright, okay. So let's see first. I mean, we only saw the P. What about the R's? Let's see the R's. Are they occurring at the same time? That's an R, that's another R. Are they about the same time?
Yes.
Not exactly, but it's about the same, right? Yeah. Okay, so can you conclude that this rhythm has a regular rhythm?
Yeah.
Yes. Okay. So can I also count the heart rate this way? So can I just count how many cardiac cycles there are in 6 seconds and then multiply by 10? I can also do that. Can I count this one though?
No.
No.
Is this a complete heartbeat?
No.
It's not, so I can't count this one. Can I count this?
Yes.
Yes, because this one has a complete PQRST. That's one cardiac cycle there. So I count 1, 2, 3, 4, 5, 6, 7, 8.
Why not?
Is it exactly 8 though?
No.
No.
It's
Because there's
80
like a-
something, correct? So 8
Yeah.
times 10, because why did I say not 80? It's 80 something because this one is part of a heartbeat,
Yeah.
right? This is about 3/4 of a heartbeat. So it's not exactly 80, but is it 90? It's
No.
not 90 either.
Because
It's
it's not
80 something, right? Remember, these are all estimates. So on a test question, will I have, let's say I give you this this rhythm strip and I ask you, what is the estimated heart rate? What will your choices be? Will I say 1, A, 80, B, 90? No,
No.
it will
No.
be a
85.
range. I'll say A, 80 to 90, B, 60 to 70, C, 70 to 80. So which one will you, it'll be
A,
A,
80 to
between
90.
80 to 90, right?
In between.
Correct. Got it? Pretty simple, right? Okay, so that's one method. Let's try another method. So so that's the R to R method. So I simply counted how many R to R's are there. And then 10 times 10, 80 something. Right. Now let's count, another method mentioned in your textbook is we count the number of small boxes in between two waves. So you can either count from two P waves or two R waves. Most people like to count between R waves because R's are very tall and pointy, right? Whereas the P, not so much. So let's look at R's, okay? So between which two R's do you want to count from? To make it easy, I usually pick a R wave that falls smack in the middle of a line. That way I can easily count the small boxes, right? But you can pick any one, doesn't really matter. You want to use this one, this
Yeah.
one, this one, this one, or this one?
That one from the.
Let's try this one.
Yeah.
So between this R and this R, how many small boxes do you see?
4, 3.
5 small boxes. 5, 10, 15, 16, 17. Is it really 17?
No.
No, it's 17 and a half, right? Okay, so I got 17 and a half small boxes between these two waves, two R waves here. How many small boxes are there in 1 minute? 60 seconds divided by 0.04.
1500.
What do you got? 1500 divided by 17.5 small boxes.
85.71.
Is it the same as our first method earlier? We said
Yes.
80 something, right?
Yeah.
Okay, so we're within that range. Okay. So what if, will it matter? What if, will I know which two R's you're gonna count on a test question?
No.
I have no idea. She may have a different set of R's, right? So I counted between this one and this one. What if John counted from this one and this one? Let's see. This time, you want to use small or big boxes? It's up to you. Okay, let's do big. John said big. Because it doesn't really matter what method you use. The answer will be the same. So how many big boxes are there between this one and this one? Big boxes, okay? 1, 2, 3, and is it really only 3?
3.5.
No, 3. Okay, so let's start, let's estimate. So if I move this two waves here,
Would be 4.
so it'll be what? 3.3
3.5.
and a half. Okay, so let's say 3 and a half. Remember, it's only an estimate. How many big boxes are there in 1 minute?
1,500.
No, that's
Oh.
small boxes.
Oh, yeah. 3.5.
So 60 seconds divided by 0.2, correct?
Yeah.
Because each big box is 0.2 seconds. Divide that into 60 equals 300. 300 big boxes in 1 minute. So 300 divided by 3.5, what do you got? 81. Is it the same?
Yes.
The same. Okay, so I don't care what method you guys use, whether the first method of counting or count by small boxes, count big boxes, will not matter. Okay, it's still an estimated heart rate. Now, this will matter what method you use. The first method we used where you just counted number of cardiac cycles in a 6-second strip works in a rhythm like this, which is regular. What if you have an irregular rhythm?
It's not gonna work.
That method will not work. Will any of these methods actually work? None will work because really, if you think about it, if it's an irregular rhythm, will the heart rate be the same from 1 minute to the next?
No.
Never. It will never be the same if it's irregular. Make sense? Okay. Question on the heart rate counting.
No.
So that's how you count the heart rate. There are 12 steps here, which we're not gonna do. We'll skip over the second step. So let's look at the QRS duration. Does the QRS duration on this one appear normal? QRS duration is supposed to be how long?
The QRS.
Less than 0.12, right? So 0.12 seconds. Is it less than 0.12 seconds? So it's between here to here. Is it between 3 small boxes?
No more.
No more than 3? Yes, it's normal. Okay, so it's no more than 3. That's 3 big small boxes there. 1, 2, 3. Okay, so that QRS complex is less than or equal to 3 small boxes, 0.12 seconds. Next step. Is it consistent throughout the strip?
Yes.
Do they look the same throughout the strip, or do the other complexes look different? They look the same all throughout. So that means so far so good. It's meeting the characteristics of a normal sinus rhythm. So they're the same shape, consistent. P waves. Are there P waves?
Yes.
Yes, we saw P wave. Is it complete? Is there a P wave before every QRS?
Yes.
Yes, for every QRS, there's a P wave, P, QRS, T, P, QRS, T, it's the same. Okay, so again, so far, this is a meeting the characteristics of a normal sinus rhythm. We looked at the rate for both all 3 methods, and they look the same, right? So and let's look at the PR interval next. So where is the PR interval on this strip?
In between.
So let's measure the PR interval. Where do we measure the PR interval from?
From the bump.
From the P wave, from here to where?
To the
Right before the
Here.
Q.
Okay, is it between 0.12 to 0.2 seconds? Is it
Yes.
between 3 to 5 small boxes?
Yes.
Okay, so that's 3, right here. That's 3 small boxes, and then 4, 5, almost 5. Right, so is it normal PR interval?
Yes.
Yes, it
Yes.
is.
So for this box, this is how we have to do for the quiz or the exam?
Not really, because again, I'm giving you the strips, so it's not necessary, but you do need to count the heart rate. Okay, for you to know is this normal or not, because the first step is always
Count.
the heart rate. So if the heart rate's between 60 to 100, is that normal?
Yes.
Yes, if it's less than 60,
No.
if it's more than 100.
No.
See my point?
Yeah.
First step is always
Count.
the heart rate, and then you can go whichever step you want there. Usually I go with P wave first. Yeah, after I count the heart rate, of course, the first wave is the P. So why would I go with the QRS, right? So I always start with the P. Are there P waves? Oh, I see P waves. Then next, what do you think I'll measure?
The QRS.
PR interval, because that's the one next, right? So I look at the PR interval, okay, it's good. And then I'll go with the QRS, and then I'll look at the ST segment and the T wave. All right. This one's kind of all over the place, so I don't like this method. I mean, these steps, because it's not in order. I mean, you can do that, but
No, I'll.
it's not, it's not a logical sequence. Okay. Here's the first QSEN alert. No matter what the rhythm says, what do you think is your first action? So let's say you're at the station, okay, so where the cardiac monitors are, and then you look at it, oh, you see an abnormal rhythm and the monitor alarm. What do you do first? Do you analyze the rhythm, or do you check the patient first? Always check the patient first, regardless of what that monitor is saying. Go look at your
It
patient.
could be artifact.
We don't know what it could be, but always go check your patient. Okay, that's the first action always. Okay, whatever the rhythm again, abnormal rhythm, run, go see the patient. All right, because patients tolerate dysrhythmias uniquely. Not all patients will look the same. All right, so let's say I have patients with VTAC. That's a dangerous rhythm. I go, patient sleeping, snoring. Okay, but then the monitor showing VTAC. Okay, so always check your patient. Whenever there's an alarm, it's easy to get alarm fatigue because just like the boy who cried wolf, right? So if someone's saying wolf, wolf, and then you go there, there's no wolf, right? So is it the same as these alarms? Yes, so it hits alarms and then you go there, oh, patient's fine. You took vital signs, oh, he's fine. He's tolerating that dysrhythmia, fine. And then you go back and then it alarms again. You go back again, same thing. So is it easy to have alarm fatigue?
Yes.
Yeah, so you think like, oh, this is like the boy who cried wolf. But should you do that?
No.
Go look at your patient each time. Or you can adjust the alarm default settings, meaning instead of putting the alarm at, let's say 60, and then you say below 60, alarm. Okay, over 100, alarm. Maybe you can adjust. If the patient's been fine at 55, can you put the parameter down to 55? Yes, you can do that. Okay, because you've already established that the patient is fine with that 55 heart rate. Does that make sense? At least you don't have to deal with the alarm constantly because you know, oh, this patient's fine. However, that's about where we'll go, 55. I wouldn't put it at 50 because, I mean, will anybody really be fine with 50 normally? Nah, I wouldn't be comfortable with that. 55, yeah, I would be, but 50, no, I want to check that patient, okay, every time he's below 50. All right, so let's look at the characteristics of a normal sinus rhythm first. So these are the characteristics. The heart rate's between 60 to 100, regular rhythm. Regular rhythm meaning, remember what we did this with the paper? Okay, it's
Yeah.
occurring regularly. PR interval, QRS, D wave, ST segment are all looking normal. That's normal sinus rhythm. And this is what it looks like. The one we saw earlier, was it also normal sinus rhythm? The
Yeah.
one we practiced on the heart rate?
Yes.
Okay, so I can either use that strip or this strip. You know that it is normal sinus rhythm. All right, we'll start with the dysrhythmias at 1 o'clock. All right.
After.
Oh.